Hello, good evening, everybody. Can I welcome you all to this all-party parliamentary group on dying well? I'm Elora Finlay, and this should be chaired by Danny Kruger, MP, but the Commons vote is running a little behind time. They're just voting now, so he's going to join us a little bit later. I'd just like to remind you of a few things. You are all on mute and your sound is off. The chat function has been disabled, or at least it should have been disabled, but I think some people seem to be using it. Please don't. It is only available to the panelists. The question and answer function is the one for you to use if you have any questions that you would like to put. Please use that function, and at the end, I hope we will have time to take some questions and go through. So we're going to start off, first of all, with a series of presentations from countries who have changed the law to physician-assisted dying, either physician-assisted suicide only or physician-assisted suicide and euthanasia. So we've got presentations from Oregon, from Belgium, and from Canada. So we're going to start with Dr. Brick Lance, and I wonder if we could check that Brick Lance has been able to come in. Sophie, please. And his slides also on screen. Can I welcome Brick now, who is an orthopedic surgeon in Oregon with 30 years experience as a clinician. And he's also the Oregon State representative for the American Academy of Medical Ethics. Brick, over to you, thank you. And thank you for joining us today.
Thank you very much. And can you hear me? Yes, so I've been in practice in the state of Oregon for over 30 years. And I've certainly witnessed the change in our culture over time. So next. This is where I practice. Next. Oregon has a population over 4 million people. Physician-assisted suicide was legalized in 1997. In fact, it was the first place in the world to have a legalization. So we do know some of the effects for healthcare in particular to what I would call PAS. Next. What does it mean to die well? Soren Kierkegaard, our great philosopher, quote, "To die well is the height of wisdom." You know, we have the opportunity in dying to set an example for others, for our loved ones and for our family. My father died well. He's a great example to me of dying in peace and comfort. Next. So we as healthcare providers can practice our care for patients at the end of life, either with the acronym FEAR, considering financial ruin, excruciating pain, abandonment, return to dependency, or NEXT, with the acronym of SAFE, stay around your loved one, acquire a listening ear, facilitate their opening up emotionally, embrace the situation to encourage, support, reassure, and provide for their needs. Next. What is the role of the physician? For centuries, and I would claim for millennia, doctors have attempted to cure and relieve suffering without injuring the patient. And as healthcare becomes more technological and more impersonal, physician-assisted suicide is dangerous for patients, for doctors, for healthcare professionals, for the healthcare system, for your local community, and for your country. Next. Trust is the key element between a patient and a doctor in their relationship. And trust is eroded with physician-assisted suicide. I've been able to witness that. Next. The four pillars of virtue practice in healthcare are beneficence, do good, non-maleficence, do no harm, justice, and autonomy. Now, if we have wrong priorities of these pillars of virtue, such as putting autonomy first, it does significant harm to healthcare. Next. We take an oath when we graduate from medical school. The Hippocratic Oath was more than 400 years BC, and that is, quote, do no harm. Our oath, I will use treatment to help the sick according to my ability and judgment, but never with a view to injury and wrongdoing. Neither will I administer a poison to anybody when asked to do so, nor will I suggest such a course. Next. So we as physicians, are we becoming vending machines in healthcare? Hope you understand that term, vending machine. There are all kinds of poor incentives near the end of life for suicide, including that for the insurance company, family, others caring for the patient, certainly financial incentives, and as alluded to, leading to euthanasia, whether it be voluntary or involuntary. Next, the American Medical Association Code of Ethics 5.8, euthanasia is fundamentally incompatible with the physician's role as a healer, would be difficult or impossible to control, and would pose serious societal risks. Euthanasia could be readily extended to incompetent patients and other vulnerable populations. Next. Pain is not usually claimed as a reason for someone to request assisted suicide. It's a burden. It's the sensation of being a burden to others, being a burden to society. That is treatable. 90% of the patients in Oregon that request assisted suicide have mental illness. In fact, in the first decade of practice with this law, only 11% of patients were referred for psychiatric evaluation. The 10th year, that fell to 0%. Last year, it was 3 patients out of 370 that requested, so less than 1%. And that number, as far as requests, is up 25% from the year before. The safeguards in Oregon are not being followed. That includes the psychiatric referral, second opinion, and the 6-month time estimate for death. The failures are brutal when someone fails assisted suicide, and the failures are not infrequent. In fact, there was one that woke up from a coma after multiple days. There was a nurse at the bedside of one who ended up putting a plastic bag over the patient to kill the patient because they weren't dying. Next. Does a human being's value and worth depend on their ability to contribute to society? I don't believe so, and I think PAS creates a hierarchy of value that is bad for our culture. Next. Whose life is worth living? Who decides? What is the value of an individual's life? Does it diminish with time? In World War II, there was different values among different human beings. I asked you to reflect back upon that time. In fact, if you go read the Nuremberg Code after World War II, I would say PAS is against that code. By National Institute of Health guidelines, this would be considered experimental. And you realize there's not another animal species that kills himself. Oregon calls it death with dignity. That is a misnomer. Dignity refers to the intrinsic value of an individual being. Next. Predicting death is very difficult. There's a Mayo Clinic study recently, 468 hospice patients, and only with 20% reasonable accuracy predicting the time of death. There's significant advances in healthcare. Dying process can be in peace and comfort nowadays. Is PAS compassionate? It was legalized as a means to prevent suffering at end of life, but it targets unfairly those with disabilities, those with chronic treatable conditions, depression, and other mental illnesses, and even organ harvesting. I would call it elder abuse, and I would call it disabled abuse, and it is substandard care, and it discriminates. Next. The American Medical Association, quote, physician-assisted suicide is fundamentally inconsistent with the physician's role as a healer. The medical profession must redouble its efforts to provide optimal care at the end of life, and request of physicians for PA should signal to the MD that the patient's needs are unmet and further help is needed. Next. The American College of Surgeons does not support legalization of PAS. It is problematic given the nature of the patient-physician relationship affects trust and fundamentally alters the medical profession's role in society. Society's focus at the end of life should be on the efforts to address suffering, the needs of patients and families, include improving access to effective hospice and palliative care. Next, regret is a real issue. There are no do-overs with suicide, and there continues to be failures with suicide in Oregon. And none of those who have failed have opted for a second go. Next. Despair, depression, disabilities, anxiety, hopelessness, all of those are treatable. The great poet Robert Frost, hope does not lie in a way out, but in a way through. Next. I want to tell you about a colleague of mine who practices PAS in Oregon. In fact, it's only a few physicians that do the numerous amount of prescriptions. He's also a patient of mine, so I've known him for decades. His joy in practicing medicine, I can just see, I saw rapidly decline over years. Next. We need to educate the public of misconceptions. Next. Hospice care in Oregon. Unfortunately, hospice care does eliminate access to other active treatment for other medical issues. And the federal law is in conflict with the state law on physician-assisted suicide. So let me read a quote from the Drug Enforcement Agency. The DEA's assessment was that delivering, dispensing, or prescribing a controlled substance with the intent of assisting a suicide would not be under any current definition of legitimate medical purposes. As a result, assisted suicide would be, in our opinion, a violation of the Controlled Substance Act. The majority of patients that request suicide are in hospice care, but the majority of hospice organizations are against it, and the majority of physicians are against it. So PAs creates challenges for the practice of palliative care, that is the physical, psychological, emotional, relational, and spiritual well-being of the patient. For palliative care is not to hasten or postpone death. In fact, there's some insurance companies in Oregon that stopped carrying cancer treatment drugs because PAS is cheaper. Next. What is your social milieu? It will change with this. I like to go back to the movie Field of Dreams starring Kevin Costner. It was a baseball movie. The great quote is, "If you build it, they will come." He was referring to baseball, but that's referring to all of our culture. If you will build this suicide opportunity, they will come, and it's going to create a negative social milieu. Let me read what a judge stated when this was first passed in Oregon. Where in the Constitution do we find distinctions between the terminally ill with 6 months to live, the terminally ill with 1 year to live, paraplegics, the disabled, or any category of people who have their own reasons for not wanting to continue living? Next. So change in society's attitude. Oregon's suicide rate has gone up overall, including violent, non-violent, not just those requesting suicide. Suicide is now the leading cause of death in Oregon. Elderly suicide is 156% of the national average. Suicide and despair are epidemic, and I think this law has contributed to it. Next. Oregon's made some recent modifications, including exempting the waiting period for some, but again, predicting death is very difficult. The drugs have changed throughout the decades, and I would consider that experimental, because sometimes it would work, sometimes it wouldn't. And now it can even take up to 2 days for patients to die after taking drugs, where in the past it could take multiple days. There are still multiple failures. Next. What does PAS undermine professionally? Where there's a joy in medicine, there's a joy of relationships. I want to share one patient of mine who was near the end of death. In fact, I spent an entire Saturday with him the week before he died. We watched college football on the TV and drank bottles of wine and told jokes. There's an opportunity when you're given a sentence of dying with your medical condition to create relationships with others, to spend time with others, and to die in comfort and peace. Next. So the top 6 reasons why PAS should not be legalized. Financial incentive for early death, invites pressure and incentive to die by suicide, covers up abuse. It's not needed. It diverts efforts. It destroys doctor-patient relationship, and socially marginalized groups become marginalized. So I encourage you as a practicing physician and surgeon in Oregon for over 30 years, do not legalize physician-assisted suicide. Do what is right for your country. Thank you.
Thank you so very much for that, and in a very short time for putting your perspective across so clearly. The next presentation that we've got for you is from Professor Benoit Boeslink. Benoit is an oncologist at a large cancer centre in Belgium. And because it's his children's parents' evening tonight, he recorded his presentation, because the time slot he was given with the teachers clashed with our meeting. So very kindly during the afternoon, he's recorded this for us, and we'll play you the video that he did today. Thank you.
I'm a medical oncologist in Belgium, and in Belgium we have a euthanasia bill since 2002. So we have 20 years of practice, and it's always interesting to look at countries which have a bill and to see what happens. And the euthanasia bill from Belgium was about medical situations without perspective, with continuous and unbearable physical or psychological suffering, impossible to alleviate, no other reasonable solutions, and a consequence of a severe and incurable disease in terminal or non-terminal situations. You will see behind any proposal for legalization of assisted dying that will be put on the foreground extreme cases of severe, unbearable, and otherwise untreatable physical suffering. And they state that doctors must be capable to stop this suffering by intentionally ending life. Behind this will always come the demand for assisted dying for autonomy or fulfilled life. One must be able to choose the moment of the end of his life. So these two movements, motivations, will always be present. but this one behind the first one. These are the number of euthanasia cases since 2002 in Belgium. We are reaching now 2,656 patients in 2019. On a global population of 11 million, this can seem a little number, but still it is 2.4% of all deaths, 1 out of 40 patients, and it's probably underreported, so it may reach 3.5% of all deaths. So this is not rare or exceptional anymore. Ending life becomes a routine. The underlying pathologies are mostly cancer, 66%, but also an increasing polypathology. This is the combination of beginning blindness, hearing loss, osteoporosis, dependency on others, 13% and doubling over some years. And then you have, for instance, also at the right, psychiatric diseases, 2%. We had patients with autism, for instance, who were euthanized. It's usually in the majority in terminally ill patients, up to 83% now of the cases, but still in 17% of cases, it's not terminal. And this group of patients, the non-terminally ill patients, is growing. It has more than doubled over 10 years. In our own hospital, you can see also that up to 30% of the patients are asking euthanasia in a non-terminal setting. The main reasons of request are very interesting to see. This is in hospital setting, so people with a physical disease. You can see that physical suffering is only 41% of the reasons for request. Then you have mental exhaustion, psychological existential suffering, social suffering, fear of future suffering, and concerns of autonomy. And both, often several reasons are combined. So it's not only physical suffering, and the cases that were shown in the media are, for instance, one of our famous writers who had the first signs of Alzheimer, a Nobel Prize winner who was facing alone his cancer. His children were living far away, a 34-year-old woman with autism, a transsexual who was unsatisfied with the results of surgery, and a 105-year-old woman tired of living. And Mark Kozijns, which is one of the founders of the bill, and also he's a lot in favor of euthanasia. Well, he says that today some persons who ask for euthanasia are not really patients. They should rather be helped with a law on assisted suicide, and maybe it should even not be doctors who decide about their demand, but social workers could do so. Every year, the Evaluation Committee on Euthanasia publishes a report, and then you can read, for instance, this kind of phrases that almost in all cases, some kind of psychological suffering is reported. It's loss of autonomy, it's to depend on others, the lack of dignity. And even if his cancer pain is perfectly controlled, this person can still have unbearable suffering by the lack of autonomy. Therefore, in the end, all suffering is psychological suffering. And all suffering is also subjective. Therefore, in case of polypathology, lowering vision, lowering hearing, need for help while eating, incapable to go out of bed, incontinence, the combination of some of these can become too much, and they get tired of living, which can be a reason for euthanasia. Doctors, moreover, they may not be paternalistic and decide at the patient's place. This is old-fashioned. So in these circumstances, how can you then decide if a disease is severe and if suffering is unbearable or not? And how to apply the criteria of the law if everything becomes subjective? So this has as a consequence that all the conditions for a slippery slope are here present, because on one hand, the offer creates the demand. Once something is possible, people will talk about it and think about it. It will be considered as a right. And if you refuse it because the law is not really, the conditions are not fulfilled, then sometimes family or patients can become angry. It's not accepted. It's in a lot of cases in non-terminal situations. It can be for psychiatric disease, for polypathology. And finally, all suffering is subjective. And this is the start of the slippery slope. And then doctors finally become the judge of the meaningfulness of life. And as a solution for these problems, they have to administer death. Well, I think that this is twice not their job, because they have to judge the physical health of the patient, but not meaningfulness of their life. And they have to protect life, to increase life, but not to shorten it. This all is also putting pressure on palliative care. In only 39% of cases in 2013, in all cases of euthanasia, a palliative advice was asked for. So in the majority of the cases, we even don't look what palliative care could do. Palliative care is now seen as an alternative for euthanasia. It's the opposite, because patients will say, look, I don't want to go to a hospice and to live 2 weeks longer. My choice is to die immediately. So euthanasia is not the alternative, it's palliative care who becomes little by little the alternative. And other patients might be afraid of palliative care because they've heard that they could be euthanized there. Difficulties for doctors and nurses. We had several testimonies also in newspapers about doctors who were performing 4 or 5 times every month a euthanasia, and they considered it as a burden for them. But sometimes as a doctor, you will have very difficult situations. General practitioner told me about the case of a man with Alzheimer who was always changing his mind about the possible euthanasia demand. Sometimes he said yes, and then he said no. And his wife became a little bit fed up, and she told in presence of the doctor, now you have to decide to ask for euthanasia. Now you have to go for it. You have decided it, you have to do it. Don't hesitate anymore. And then as a doctor, you have to perform euthanasia when the patient is hesitating, but the family is asking for it. So this is an example of the difficult situations that you can see. When you have severe physical suffering, well, this is a medical issue. It's limited number of cases. It's objective when it's difficult to control the symptoms. But we have medical therapy, we have palliative care. If necessary, we have palliative sedation. And in fact, there was no problem to solve the problems in this way. On the other hand, you have existential suffering and autonomy issues. This is not a medical issue. This is imprecise. This is subjective. Once that you introduce euthanasia for severe physical suffering, for this limited number of cases in medical situations, you will open the door for euthanasia in cases of existential suffering and autonomy issues. And you will create an important problem, whereas here, before the bill, there was no problem. And in most countries, we can work without a law on euthanasia. So finally, do we have to change our way to look at disease and suffering? Is this not the issue? Because my feeling is that we have replaced solidarity by autonomy and care by death. Life before was sacred and valued. Autonomy is now sacred and dominant. Dignity is now just reduced to autonomy. But strange, again, not the autonomy of doctors and the institutions they are working on. This is not respected because there are movements to promote euthanasia in all kinds of institutions. What is finally specifically human? Is it to take care of each other, to find happiness and generosity, or is it to be autonomous, to not be a burden? And I will end with this slide. This shows 2 ways of looking at care and medicine and society in general. And you will have to choose one of both. On the upper picture, you see one of the promoters of euthanasia in Belgium, who once told that a close member of his family jumped out of the window of a hospital because he could not bear anymore his terrible suffering. At that moment, euthanasia was not possible. Therefore, we needed a law on the depenalization of euthanasia. The second picture shows a religious, a nun, Sister Leontine, who was also a medical doctor, and she had seen her brother dying of pancreatic cancer in difficult circumstances. And she decided at that moment to start palliative care in Belgium and opened the first hospice. So the situation, the problem was exactly the same. But in the first case, death was chosen, and in the other, to add life to the days that remain in palliative situation. And strange, but interesting, when 3 years ago, the NIP test was fully reimbursed in Belgium to detect chromosomal abnormalities in the blood of the mother while pregnant, to detect Down syndrome and other diseases. Professor Vermeersch, the promoter of the law, told that he hoped now that finally with the NIP test, children with Down syndrome would be extincted. So this is the solution of death or the solution of care. There we have to choose as doctors and you as politicians. Many thanks for your attention.
I hope you all found that interesting, as I certainly did, and I'm sure that we all are very grateful to Benoit for making time in the afternoon to do this, so that he wouldn't be, so he'd be free this evening. We're now going to go back across the Atlantic and go to Canada to Dr. Leonie Herx. And Leonie is a palliative care physician in Canada, and she is the divisional chair of palliative medicine at Queen's University and past president of the Canadian Society of Palliative Care Physicians. And Leonie, can I welcome you and thank you for coming to present to us tonight. Thank you.
Thank you. I just wanted to do a sound check, make sure that you can hear me okay.
Very good sound.
Okay,
thank you.
Excellent. Thank you. Thank you. I'm speaking to you today from beautiful Kingston, Ontario, Canada, as a settler on the traditional territories of the Haudenosaunee Confederacy and the Anishinaabe Nation. Today, I would like to share with you some of the experiences we've had over the past 5 years of legalized euthanasia and assisted suicide in Canada and its impacts on the practice of medicine. First slide. What is medical assistance in dying? Medical assistance in dying is lethal drugs that are given to end a life, also known as MAID in Canada, and it includes both euthanasia and assisted suicide. So in euthanasia, the drugs are usually given by injection by a practitioner, and in an assisted suicide, the patient takes the drugs him or herself. When both are legalized, as is the case in Canada, euthanasia becomes the easy option for patients. Last year in 2020, over 7,500 MAID deaths were by euthanasia and only 7 by assisted suicide. Next slide. The progression of the Canadian legislation. In 2016, Canada legalized assisted dying for those with a reasonably foreseeable death. Canadians believed this would be for exceptional circumstances of intolerable suffering when a person was dying. Since then, eligibility has been expanded through widening interpretations of the legislation and court rulings. For example, in Ontario, a 77-year-old person with osteoarthritis had euthanasia after a judge ruled that the reasonably foreseeable death criterion did not require a specific prognosis. In March 2021, the reasonably foreseeable death requirement was removed entirely. From March 2023 onwards, euthanasia will be available for mental illness as a sole condition. Progressively, safeguards put in place to minimize harm have been eroded, as they seem to serve as barriers to accessing euthanasia. Further expansion of MAID is happening in stages in Canada. A parliamentary committee is now exploring euthanasia for mature minors and advanced directives. MAID is also being requested for children. A mother's request for the euthanasia of her young disabled child is now being championed by our parliamentarians. Next slide. Under the current Canadian legislation, the eligibility for euthanasia now includes chronic disease. Some of the examples are listed here on this slide. Disability, which is very broadly defined to include anything that hinders a person's full and equal participation in society. Even deafness, blindness, and dyslexia would be included. And mental illness alone, as we've said, will be available in 18 months. Next slide, please. There have been over 20,000 assisted deaths in the past 4.5 years in Canada since legalization. We only have statistics reported till the end of 2020 at this point, but the numbers have been increasing each year. There was a 35% increase from 2019 to 2020. Assisted deaths now account for 2.5% of all deaths with significant regional variation. For example, in Quebec, it accounts for about 3.1% of all deaths, and in British Columbia, about 4% of all deaths. The original picture painted of euthanasia being a rare event for very extreme circumstances, with estimates of about 100 requests in the first year, has not been our reality. Next slide. As in other countries who legalized assisted dying, Canada's data shows that requests are due to psychological and emotional distress around the fear of dying, including fear of being a burden to others, the loss of the ability to enjoy life, and a desire for control. It is not due to poorly controlled physical symptoms such as pain, contrary to the portrayals in the media and the euthanasia lobby groups. Next. At the outset, we were told in Canada that a carefully designed and monitored system of safeguards would limit harm and any risk of wrongful death of vulnerable persons. Yet every year, there have been documented cases of non-compliance with safeguards and misapplication of both law and policy with respect to MAID. The Chief Coroner of Ontario, the End of Life Care Commission in Quebec, the British Columbia Coroner Service, and the Correctional Investigator of Canada have all reported these issues. Next. We see reports of Canadians seeking euthanasia due to loneliness and depression from social deprivation and due to the inability to access the care and support needed for living through high costs of care, poor conditions in care homes, fear of loneliness in COVID lockdowns, and prisoners who are refused parole. Next. We also have reports of disabled Canadians being pressured by healthcare workers to consider euthanasia because of their ableist attitudes about perceived quality of life or the high cost of their care. One example is Roger Foley from London, here on the right side of the slide, who required 24-hour care due to a neurological condition. While in hospital, Roger taped a hospital administrator suggesting he should get MAID because of the cost of his care. Next slide. Many requests for euthanasia come from fear of being a burden to others. This sense of being a burden and loss of dignity is amplified when resources to support living do not exist. Disability rights groups have condemned the expanded Canadian legislation as making disabled people feel less valued in society by giving them a fast track to assisted suicide rather than suicide prevention and assistance in living. The Canadian Federal Minister for Disability Inclusion has said, in some places in our country, it's easier to access MAID than it is to get a wheelchair. Next. The impacts on medicine have been profound. Euthanasia in Canada has been radically normalized as routine medical care. The euphemistic language of medical assistance in dying has contributed to this by confusing and equating euthanasia with palliative care. MAID is represented as just another tool in the end-of-life care basket, but euthanasia is not end-of-life care. It is ending of life. This is a seismic shift for physicians. A desire to die often comes from grief, anger, loss, and despair as people adjust to a devastating diagnosis or a change in their condition. This lament, often a cry for help, now often results in an assessment for euthanasia before palliative care or psychosocial support has been involved. Some doctors in Canada are now facilitating suicide completion rather than providing suicide prevention. An example is an actively suicidal patient seen in an oncology clinic with all the red flags for high risk for suicide completion, previous suicide attempts, prior history of depression, a clear plan, and access to weapons. Psychiatry was consulted, and rather than admitting the patient, they gave the patient the means to end his life himself through MAID. Some physician regulatory bodies and associations suggest that euthanasia should be raised with patients alongside all other therapeutic options. But euthanasia is not like any other option. It is irreversible. If a doctor offers unsolicited euthanasia as an option to a patient, this can easily persuade a patient to pursue it. Patients take a doctor's recommendation very seriously due to the trust in their expertise and that they have their best interests in mind. All healthcare facilities in Canada are now expected to provide euthanasia regardless of their philosophy or focus of care. We heard earlier that hospice's core philosophy does not include hastening death. But recently, we see an example of a hospice in BC that was closed down. Government funding was cut because they refused to provide MAID on site, even though patients could access MAID next door at the hospital facility. There are really no euthanasia-free safe spaces now. Next slide, please. The impacts on medicine are significant with respect to the role of the physician as well. Under Canada's legislation, a patient seeking an assisted death only needs to be told of their options for care, even for potentially treatable conditions. But being told about something and experiencing it and the benefits of treatment are very different. This allows death to be administered as a first-line treatment in Canada, and it has significant implications for a doctor's ability to practice medicine according to their conscience. Conscience is not about religion. It is about being able to practice medicine with professional and moral integrity, being able to provide recommendations within the scope of their specialty, in the patient's best interest and within the medical standard of care. A doctor knowing of a treatment that can address the cause of the suffering leading to a euthanasia request that has not even been tried is required to facilitate ending a patient's life because that is their choice. Many physicians can't do that in good conscience. Next slide. There is no robust legislation that can protect doctors, pharmacists, nurses, and others from having some involvement in facilitating assisted death, even when they feel professionally that is not indicated or necessary. Participation is forced in some of our jurisdictions through institutional policies and regulations, such as in Ontario, where the college requires doctors to make an effective referral and find a MAID provider or risk disciplinary action, such as loss of license. With the legislation expanding to those with chronic illness and disability, many more doctors are calling for better conscience protection, as almost every medical specialty is now being impacted by MAID. Next slide. Assisted dying has been romanticized as the most beautiful death and marketed as the only way to die with dignity. This has perpetuated myths and increased fear about natural dying and death, which is most often very peaceful and comfortable. And specialist palliative care must be made readily available to support a comfortable death for those few people with more complex symptoms. Those who voice concerns about patient safety or advocacy for the safeguards needed to prevent wrongful deaths in Canada have been dismissed as being anti-MAID or accused of trying to block access to MAID. We are also experiencing significant bullying and marginalization within medicine and institutions for those who are not championing euthanasia. This is causing division and conflict within the medical profession. In my experience, there is not a day that goes by now that doctors are not facing an ethical dilemma or moral distress about euthanasia. It is exhausting and demoralizing. Many colleagues have stopped practicing palliative medicine because of this. I keep going by knowing that those patients who do not want euthanasia will not have other options for care if we all leave. Next slide. I'd like to end with this quote from Canadian bioethicist and physician, Dr. Nuala Kenny. Legalizing euthanasia fundamentally changes medicine, the role of the doctor, and our society. Once brought into medicine, there are no rules or safeguards that you can put in place that will keep euthanasia restricted to a very few with extenuating circumstances, as is portrayed by its proponents. Don't be deceived. Administering death is cheaper and easier than providing care, and it will quickly become the solution for any form of human suffering, as we are seeing now in Canada, period. It is not a slippery slope. It is a logical progression. Thank you.
Thank you very much indeed, Leonie, for sharing your experience in Canada and sharing it so openly with us. The next presenter that we're going to go to is Dr. Satya Chandagiri, who is from Oregon. Dr. Satya, as I'm calling him because it's slightly easier, if I may, is a psychiatrist in Oregon with experience. He is originally from India. He qualified in Bangalore, but has now been working for some time in Oregon and knows the Oregon law very much from the perspective of a psychiatrist. So Dr. Satya, if I may hand over to you. Thank you.
Thank you very much. Good evening, honorable members of the Parliament and dear colleagues. And thank you for allowing me to share. Can we go to the next slide, please? I'm a psychiatrist. The aim of my work involves improving lives and preventing suicide and not facilitating suicide. There are real challenges on the front line. I am a board-certified psychiatrist practicing in Oregon, United States of America, and have 32 years of experience in my field. I'm going to start with this example. Let's take the example of a retired physician. Surgery removed his seriously cancerous kidney. While delirious post-operatively, he was asked to make his end-of-life care decisions by the intensive care unit doctor. He stated he did not want to live, and the physician took that to mean stopping all care. On his wife's insistence, the physician called me. I had served him for years and knew he was planning to visit Australia to be with his family and his future wishes. Ending care was not in his plan. This changed the course of his care completely, and he's still alive today. It's so easy to take things at the face value and get carried away. So this is an example I wanted to share. Now, let's go to the next slide, please. So Oregon's Death with Dignity Act, you heard from earlier, essentially it comes down to who chooses voluntary self-administration of prescribed lethal drugs. And there are certain conditions to follow. I'm going to quote from Dr. Linda Ganzini, a colleague, a psychiatrist colleague, now retired. She's worked extensively and published in this field. Has said the legislation catered to only a very small group of people. Unlike hospice and palliative care, it has less to do with relief of pain, suffering, reconciliation with their family members towards the end, and more to do with having rigid, complete control of their life till the end, and often they displayed marked narcissistic personality traits. So why do people seek death? Based on our experience in our state, the three most common, frequently reported concerns that lead to seeking this option was decreasing ability to participate in activities that made life enjoyable, losing one's autonomy, loss of dignity. These are societal issues. It is so common. Culturally, it's often people refer to this far more than being medical problems. Inadequate pain control or concern about it is a reason in less than a third of the people as the reason for choosing Death with Dignity Act in our state. The next slide, please. So now let's, in my work, I do a lot of capacity evaluation as I take care of a lot of elderly folks with brain injury, geriatric issues, and brain neurological conditions with psychiatric conditions. Capacity evaluation is easier said than done. There are serious challenges in the capacity evaluation in terminal phase of life. Most physicians are not well trained in forensic or geriatric psychiatry and find it very hard to perform a thorough capacity evaluation, especially with high risk consequences. At this stage in life, people are confused with fluctuating consciousness. Many cannot comprehend instructions or communicate due to language and speech limitations. They have severe cognitive problems. They have high likelihood of undiagnosed depression and dementia. Their capacity can be affected by a wide range of conditions and medications they take. Delirium, traumatic brain injuries, neurological conditions such as Parkinson's disease, underlying medical conditions, including heart disease, lung disease, liver disease, fear, pain, fatigue, worry can all affect capacity. Patients' ability to comprehend and express language is very important in obtaining consent. So let's go to the next slide, please. So the medical capacity evaluation, especially when it comes to such high risk end-of-life decision, requires 4 aspects to be evaluated, including understanding, expressing a clear choice, appreciation of the facts and how it relates to themselves, reasoning ability to compare options and infer consequences. One can be verbal and make a choice, such as stating, I don't want to live, but may still fail to meet other 3 standard of capacity evaluation. Expressing a clear choice alone does not demonstrate patient has capacity. When my patients with schizophrenia stopped eating, started refusing kidney dialysis, stating that she was ready to meet her Lord and she was cured and we were lying to her, it did not take much before she became delirious. I had to place her on involuntary psychiatric hold because she was clearly demonstrating lack of capacity, even though she could express a choice, and started her back on involuntary antipsychotic medication. And soon she was back eating and continuing her dialysis. Many non-terminal illnesses can quickly become terminal if one withholds or refuses treatment in this case. Once again, the capacity changes over time. The prior self and today's self may have different capacity. Having capacity at the time of prescription may not mean that it is the case at the time patient is ingesting the drug, as many hold on to drugs for a long time. So let's go to the next slide, please. So what exactly is involved? I mean, I had to reflect on this to let this sink in. This is what Lisa from California described of her aunt's assisted dying. She was there in that moment. The full cocktail included 2 anti-nausea pills, an anti-seizure pills, and 100 capsules of secobarbital. My attention turned to the kitchen table where my husband and sister, wearing latex gloves, frantically scraped the powder from 100 capsules with toothpicks, trying to beat the clock. The mountain of powder we poured into more sugar syrup created half a cup of sludge so bitter it literally burned my tongue. The day was fraught and frightening. We had been forced to assist in the most bizarre fashion, jumping through seemingly random legal hoops and meeting arbitrary deadlines, while my aunt suffered, and finally emptying capsules, making an elixir so vile, I cried when I knew she had to drink it. This was death with dignity. There is no dignity in this kind of death. And you heard from the previous speaker, sometimes it drags on for 2 days. I had to reflect on this to let this sink in as a physician, having worked hard and having dealt with patients who are suicidal, who have completed suicide and died by suicide. So this is probably what it really means. So let's go to the next slide, please. Turning healers into killers. My work involves saving lives, not deliberately shortening life. Are we abetting suicide? Physicians will become sellout to a system that wants to cover up the lack of healthcare equity. Instead of improving our healthcare system, are we asking our doctors to participate in this cover-up of a failure? My state, Oregon, has been ranked at the bottom of mental health care system in US for long. We are 49th out of 50 in 2021. Suicide is the leading cause of death in ages 10 to 24 and in the elderly. Firearms, overdoses are the leading cause. Access to geriatric care is dismal, as many will not accept the federal Medicare insurance. Politicians are looking for reasons to cover up this failure. Wish to hasten death in terminal stage of life is a complex challenge. Many studies indicate depression, hopelessness, low sense of spiritual well-being are the strongest predictors of a desire for hastened death in terminally ill. The lack of joy, purpose, not feeling useful is a common expression and should prompt further exploration of factors one can mitigate and not rush to prescribing death. It is found in all cultures. While most individuals requesting this do not carry a diagnosis of depression on their chart, however, studies have suggested that quarter to half of the requests came from individuals with depression. Unfortunately, as you heard in Oregon, only 1.2%, that's 3 of those who requested, were referred to psychiatric consultation in 2020. Many more may have undiagnosed treatable disorders such as depression. For patients, for example, patients diagnosed with cancer are at high risk of dying by suicide. Did we end up missing treatable causes? Is always an open question for me. Let's go to the next slide, please. It's an ethical slippery slope. We are dealing with death on demand, with physician shortage in both our countries. Difficult to have physicians to remain with the patient when they self-administer the drugs. In 2020, for instance, only 11.8% of the patients, the physician was present at the time patient ingested. Nearly 48%, there was no one there. If patient wakes up, what do you do then? They're told not to call 911. not to take them to emergency, as that will lead to police report. And in about a third of them, they are ambivalent. They're not deciding which way to go. There's always the ethical dilemma, as some physician and hospice care providers feared breaching their institutional policies and becoming subject to litigation and abandonment. Death on demand, physician-assisted suicide or euthanasia is not part of hospice and palliative care. One participant explained it so well. This is a sudden end to death, a more determined time, date where life will end. In 2020, for instance, the patient-physician relationship was 8 weeks, anything from 0 to 1,020 weeks. There was not much time or relationship with the patient to evaluate the patient completely and decide which way to go. So let's go to the next slide, please. Dead don't speak. There is zero accountability, oversight, and no complaints so far. We have been having this law for close to 20 years now. Law does not include any oversight or regulation, and the records are destroyed after 1 year. The death certificate simply says death as from natural causes. Only 2.2% of the Oregon physicians prescribed it. This is an unregulated practice. As there is no peer review, medical board is not aware of who practices what they prescribe. There is serious risk for safeguard and requirements to be ignored. It has become like a runaway train, and we have to be cautious. And please do not allow this to be an option in your country before you lose track of what is going on. So thank you very much.
Thank you very much, Dr. Satya. And for the last part of our meeting, we have another presentation from Belgium, and that is Professor Dr. Timothy Devos. He also kindly recorded a piece for us because he couldn't join us today. So we'll go straight over to that. And then for those who want to stay on, we'll look at some of the questions that have come in. Thank you.
In Belgium, the laws on palliative care and euthanasia were voted through at the same time in 2002. Since then, all media attention has gone to euthanasia cases, and palliative care has failed to receive either comparable public attention or sufficient and promised financial support. As a consequence, when reflecting about the end of life, my patients have only two ideas in mind. Either they will suffer or they will ask euthanasia. It's a horribly grim choice, and it shows an enormous ignorance about palliative care and its benefits. For me, this situation is a good occasion, a good opportunity to propose them palliative care as the third way and explain them the tremendous possibilities of palliative care nowadays. In 2002, when the law was voted through, euthanasia was presented as a rare exception of the legal prohibition of killing, permissible only in rare cases of extreme, uncontrollable suffering in terminal patients, for example, in those suffering of asphyxia, those with extreme pains, or those with pre-terminal anxiety, and also made at the request of an adult with mental capacity. Now, almost 20 years later, euthanasia is increasingly applied to take the lives of non-terminal patients, like psychiatric patients or older patients with the so-called polypathology, a combination of different non-terminal diseases and conditions in the elderly. Sometimes euthanasia is proposed by healthcare workers to patients directly as recommended solution to their suffering. As we show in the book, Euthanasia, Searching for the whole story. It has become considered as the good way of dying. We as a society went from tolerating euthanasia to normalizing it and conferring upon a moral acceptance. And we have now reached the situation where euthanasia has become a banal and everyday fact of life. The number of deaths by euthanasia has increased incrementally each year as the practice of euthanasia shifted from the initial idea of an exceptional procedure for exceptional situations to the absolute right of the patients to end life when life is considered not to have sense anymore. Yet, palliative care is the opposite. It is the opposite of this. Palliative medicine is about doing everything to give a sense of meaning and purpose to the last days of life, to stimulate care and solidarity. Tragically, it has become extremely difficult to give good palliative care while a patient has the euthanasia paperwork ready in the nightstand and asks for euthanasia on a difficult day, requesting another doctor if their request is not immediately granted. The doctor and the whole palliative care team are then transformed into an instrument of the patient's desire, amputated of their vocation to care and to heal, and treated like furniture. I do not believe in the so-called integrated palliative model, a model where palliative care and euthanasia go hand in hand. The evidence suggests the opposite to be true. In palliative care, the patient and the doctor share a commitment, an alliance. Doctor and patient accept that they have a real responsibility towards each other. The ultimate aim is clear. In the end, a death with authentic dignity, respecting the ethical framework of both patient and doctor. The way to get there is intrinsically different between palliative care, which is about guiding the patient through the natural process of dying, and euthanasia, which is intentionally inducing death on the patient demand. With euthanasia, the patient-doctor relationship becomes a contract, and the doctor is turned into an instrument of delivering death. Another evolution which shows that palliative care and euthanasia do not go together is this. Initially, it was thought that euthanasia would only be accepted after applying the so-called palliative filter, which means that first, all the possibilities of palliative care should be proposed and discussed with the patient requesting euthanasia. Now, almost 20 years later, applying the palliative filter is attacked. It is attacked as a barrier impeding the patient to receive the euthanasia he wants. Now it is said, by proposing palliative care, doctors obstruct patients who want euthanasia. It is even illegal because trying to convince a patient about a certain management is against the law on patient rights. That's where we are. The palliative filter sounded like a nice theoretical concept when the law was developed. Now, almost 20 years later, we see it does not work at all. As euthanasia becomes normal, the right of conscience of doctors and health workers is increasingly under pressure. As euthanasia is considered as the good way of dying, why should a doctor refuse? Is he heartless? Without any empathy? The pressure of the family on doctors to administer euthanasia is heavy. Nobody cares about mental and emotional charge on doctors performing euthanasia, how it changes them, and how they try to cope with it. A citation from the book Euthanasia, Searching for the Full Story. I had the pleasure to coordinate this book together with several experts from Belgium. In this book, a nurse writes, "I have been witness of the deep distress that doctors experience when they perform euthanasia, such as one experienced and qualified doctor. His eyes filled with tears as he confessed that some nights he wakes up in sweat, seeing the faces of the very people he has euthanized in front of him. Be aware that once the door of assisted suicide euthanasia opens, it will always open more." That's the way it has gone in Belgium and in all the countries without exception where euthanasia has been legalized. You would be deluding yourself if you imagined that it would be any different in the UK.
I think that was a very powerful message coming through. Now, I'm aware that it's 8 o'clock. Some people have to go. Danny has asked me to thank everyone on his behalf. He has been with us for most of the meeting, but didn't interrupt because of the votes, and meaning he was a little bit late. I think we will just carry on, but do understand, of course, if some people have to go at 8. And the reason I want to carry on is that we do have some really interesting questions that have come in, and I would like to invite Brick and Leonie and Satya, if they could come back into the room, Sophie, if that's okay, to be on the panel. And whilst they're coming back in, one of the questions that's come in has been to say several surveys in the UK have shown that many of the public don't understand the differences between assisted suicide or euthanasia and a change to symptom-directed rather than disease-orientated care. In their clinical practice, have you as panelists found any ongoing confusion about the differences between assisted suicide, euthanasia, stopping treatment, and palliative care? And I think what I'd like to go to Leonie first, and then ask you just each to be very brief in your answers, because then we can get a couple more in. Thank you, Leonie.
Yes, thank you. That's a very good question. I did allude to the confusion we've experienced in Canada around patients thinking that when they're asking for MAID, medical assistance in dying, what they think they're getting is comfort while they're dying so that they're not having uncontrolled symptoms, which in fact is palliative care. So that use of language has caused harm and confusion to palliative care, because people think when they're getting MAID, medical assistance in dying, they're getting palliative care. And so they don't actually understand that it's a lethal injection or a lethal dose of drugs they can take themselves. So it definitely has been a concern. And I feel that the general public does not understand that people have already a right to understand what options are available to them. And if a medical treatment is too burdensome than the benefits, for example, a 3rd round of chemotherapy, or if it's causing harm for their quality of life to continue dialysis, stopping life-prolonging treatment is a choice people get to make, and is part of good palliative care and being a good doctor to help guide people through those decisions. That is not the same thing of intentionally immediately ending life through a lethal dose of drugs, which is what euthanasia and assisted suicide is. Thanks.
Thank you. And Brick, I mean, almost a one-word answer, because I want to come to you about something else in a moment. Have you found that confusion in Oregon? I saw Satya nodding.
The simple answer is yes. And the most appreciative patients and families are those when we explain the situation and then help them through the dying process. They're extremely thankful.
Right. And Satya, you're nodding, so I presume that's your experience too.
It is. As one hospice medical director shared with me, if you let me do my job properly, you will not want death. In other words, they have so many tools in their hand. If you really, so they can make it so much better. The problem is we don't let them do their job.
Thank you. I'm just going to push us on a bit because, Brick, I want to ask you something because you were describing that really it's only assisted suicide in Oregon. And I wonder if you can just in one sentence try and explain whether you feel that other countries that don't have that conflict between federal law and state law can legalize assisted suicide without having mission creep into euthanasia, or whether that prohibition that you've got in federal law, it has acted as a bit of a break.
Well, it does. As you know, in America, we have a strange legal system compared to others because we have the state authorities for numerous decisions where the federal government also has statutes. And that covers a lot of other issues, even beyond healthcare, but certainly ones within healthcare. So what typically happens in issues like this is the federal government just doesn't change their law, but they also don't seek out those who are breaking the law. So they do it with a blind eye. They just close their eyes. That's what happens.
Thank you. And Leonie, a question that's come in, which is, why is euthanasia the preferred option when assisted suicide is legal as well?
Well, that's a very good question. And my experience tells me that it's easier to have something done to you than to do something yourself. It makes it kind of, medicalizes it. What's a doctor doing this for me? Much harder to do it yourself. Perhaps that's not what you really want.
Thank you. And Satya, you referred to the drugs, and a question has come in as to how well researched are the drugs and the doses that are currently prescribed in assisted suicide, because they do seem rather strange cocktails.
They are strange cocktails. They are not being researched. They are just like, it's not used, no FDA indication for this. They are just put together because the previous combination became very expensive. There's a guy who was making money out of it. So they just came up with their own cocktail. The guy was charging $3,000 or $5,000. And then he's probably facing some legal complication. So this is a big problem. This is the same as death penalty drugs, folks. It's no different. So then they moved to this combination, which, as Dr. Lance nicely described it keeps dragging on. One of those drugs is the antidepressant, which I used to prescribe long ago. And it's such a difficult thing because we would have patients who would overdose on suicide and not all of them would die. And that led to all kinds of difficult things. It brings up difficulty.
So thank you. And Britt, back to you, because there's a question here about wanting to understand more about when it doesn't work. And it would be helpful to have a little bit more evidence around this. I think your data came from the Oregon Health Department, official reports, if I'm right, but I just wonder if you have a comment on that.
Unfortunately, I don't have in front of me in Satya unless you have the actual percentages, but there is what I would call significant percentages who fail suicide every year. Now, I will tell you, though, it's probably greater than what is even released by the Oregon Health Authority, because there is a lot of underreporting on this issue, significant underreporting.
Thank you. And then one of the, and I think that this will be our last question to you, really, but we're being asked about NHS freestyle healthcare that we have here. Do you have that type of healthcare here? Someone said they can't imagine death being offered as a first option here because of our NHS. And I just wonder whether what you feel about the way that your insurance systems might be in conflict with ours.
I can make just a couple comments. Once you reach the age of 65, you go under Medicare. Most people over 65 have that as their primary insurance. You can have secondary. So there is federal statute for everybody 65 and older. And so that is a huge problem. Most states also have a state healthcare program run by the state. In Oregon, it's called the Oregon Health Plan. And so anybody who does not have private insurance will be under that plan. So yes, it does exist within both Medicare and the Oregon Health Plan. It's there.
And Leonie, because Canada, there's quite a lot of similarities between Canada and the UK generally.
Yeah, none of us ever imagined that death would become a first-line treatment, but your legislation, the draft I read, is very similar to ours in that a patient only has to be told about their options. That's not having tried and failed treatments that are in other countries. They've said it's a last resort when all other options have failed. So it will become a first-line option, as I think we've all heard here from every speaker today. It becomes the quickest and easiest option, and that's just what people think they should have. They don't want to try anything else.
Great. Thank you very, very much. Baroness Hollins, actually, and as a parliamentarian, we always have a principle that we let parliamentarians' questions come through, so I will put hers up. And that is whether any of you have got experience of people with intellectual disabilities or autism being offered euthanasia. I think one of you referred to that in your talk. But Satya, with the difficulty of assessing capacity, do you know of people who've had intellectual disabilities who've gone down that route?
I personally do not have, and there is no way we can go back and study whose diagnosis was, because in the state of Oregon, the death certificate simply says death due to natural cause. Second thing, it's destroyed. The record tracking sheet is destroyed after 1 year. So there is no peer review possibility. There's no way to go back and study. These are all self-reported data, which is compiled in the state's website, and it's almost like a year or two behind. So this is really a slippery slope, and I would really caution everybody, this is like a runaway underground business. You don't want to get into that, and then where it stops, we don't know.
Yeah. Great. Do you want to add to that, and then I'll go to Leonie?
Yeah.
Just real quickly. Yes. So the primary care doctors, in fact, including my colleague, my patient, who does the prescriptions, they have very little understanding of a spectrum of autism and disabilities, and including mental illness. And so they take it upon themselves to make a diagnosis which they are not educated to do. And that happens routinely.
Yes, 2 quick points on this. So assessing capacity in someone that has an intellectual disability and dementia, there's no formal training required for Canadian providers of MAID. And it is very complex. Like you could have a whole hour teaching session on the complexities of assessing capacity in these types of situations. But we have actually had a very public case in the media of a man who had an intellectual disability. I can't remember if it was autism. I can share the details with you if you'd like, who got convinced and had MAID, and his family contested how they were actually not allowed to be involved in, they had always helped him make his medical decisions previously. And in this case, the MAID team wouldn't allow them to participate. And they felt that he didn't understand what he was asking for, and wouldn't have actually chosen that if he had fully understood. So they're actually contesting that situation.
Baroness, I have a quick remark here. Most of the folks I take care need assistance in giving their day-to-day medication. They need assistance in reminding them when it is to be taken, how many they are going to be taken. So leaving it to that person to decide how to take all this and self-administer is almost impossible. And what they may not be the ones, I mean, essentially the previous self is not the one who is taking it now. Yeah. So this is the kind of practical ground reality we deal with on a day-to-day basis. People make medication errors because they don't know what they're taking, how many they have taken, have they taken. So to allow them to take a bunch of pills, lethal drugs is...
Well, they probably wouldn't swallow them down, actually, because there's so many that they'd have to swallow. I'm going to stop there because we're now run nearly a quarter of an hour over the time that we'd allocated. I'm extremely grateful to the 3 of you on a different time zone, having done this for us and spoken to us tonight. And I will also convey our thanks to our 2 Belgian contributors who recorded yesterday and earlier on today for us. so that we could have the benefit of their recordings. And I know that Danny Kruger and the other officers of the All Party Parliamentary Group also want to convey their thanks. So thank you to all. This has been recorded and it will be available on the website. Thank you.